Absolutely terrified. The doctor's telling me my child's going to die. We're talking 48 hours, 72 hours. He's actually just scaring the death out of us.
I think it's absolutely critical to understand that transparency begins with the informed consent concept, with the commitment to reach a patient on every level, and that disclosure in that sense, in a benign sense of that word, is simply nothing more than a commitment to be honest with patients from the beginning and throughout that therapeutic relationship.
By the end of this film, viewers will be able to describe why transparency begins with the first conversation between doctor and patient, define the characteristics of and differences between informed consent and shared decision-making, describe how shared decision-making is critical to transparent, patient-centered care, and how it can improve outcomes while reducing medical liability and overuse of care. Appreciate that shared decision-making is a process, not an event, requiring modifications and regular updates that reset patient expectations. And understand the value of having family members or friends present during informed consent and shared decision-making conversations. Michael was a handsome 22-year-old man with a penchant for making people laugh. The only child of Patty and David Skolnik, Michael enjoyed being the center of their close-knit family. Active, involved, and always eager to participate. Whether he was sharing time with his father rebuilding cars in the garage, an activity that often made Patty feel like she had two children, or out on the water sailing with his uncle, Michael embraced life with a passion. As a young boy, Michael would often assume the role of caretaker, protecting those around him, especially those in need. It came as no surprise to Patty and David when he began working as an emergency medical technician, moving back home to attend college with the goal of becoming a registered nurse. On the afternoon of Monday, September 17th, after losing consciousness while playing with his dog, Michael's life would change forever. This was the second such episode within the last 3 months. The emergency department physicians who examined Michael believed the 2 episodes may have been seizures, secondary to medications he was taking. A CT scan of Michael's brain performed in July was read as normal. However, a repeat CT scan of the brain at this time reveals there is a 3-millimeter round hyperdensity in the midline near the foramen of Monroe, anterior to the third ventricle, could represent a colloid cyst. The remainder of the brain is unremarkable. Specifically, the ventricles, sulci, are of normal size for this patient's age. Recommend further evaluation with MRI. This does not appear to create any ventricular obstruction at this time. A recommended MRI of the brain was obtained the following day, Tuesday, September 18th, and confirmed a 4.2 millimeter lesion at the foramen of Monroe. This is consistent with the history of colloid cyst. It is causing no obstruction at this time. Michael has a very small cyst located near one of the ventricles in the brain, an area where fluid is normally found. Both CT and MRI scans show no evidence of increased pressure in the brain. Michael's primary care physician recommends he be evaluated for a possible seizure disorder. His mother contacts a physician friend for a referral to a neurologist. The Skolniks, however, are given the name of a neurosurgeon. Patty calls the neurosurgeon, who states Michael's condition is very serious and he needs to be admitted immediately to an ICU at a community hospital where he has privileges. Upon admission to the hospital, the neurosurgeon tells the Skolniks that in order to save Michael's life, he will need to emergently place a drain in Michael's brain to relieve the excess fluid and pressure building up in his brain.
So at that point, I know I was feeling so grateful because they obviously missed this in the ER because he's the neurosurgeon and he was saving our child's life.
For the informed consent process to meet the legal and regulatory requirements, the following elements must be met. 1. The patient or their designee must be competent at the time of the discussion. 2. Once competence has been determined, there must be an accurate description of the proposed treatment or procedure and who will be performing it, a discussion of relevant risks, benefits, and alternatives, including the risk of doing nothing at all, and finally, an opportunity for the patient to ask questions. The Institute of Medicine defines patient-centeredness as providing care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. To make consent properly patient-centered, clinicians need to ask patients what they want from treatment before they discuss treatment strategies. Michael signs the consent for the drain placement.
Michael did sign the consent for the ventricular drain, that first procedure, but we discussed it as a family. And the doctor stayed there and he knew we discussed this as a family, that this was definitely a nuclear family of 3. He didn't tell us there were any risks or, there were only benefits. I think we were just so naive at that point and were just so relieved that he was going to save him.
My assumption, he was going to go to an OR. He was going to have high-tech point-point accuracy to make this drain, this preliminary drain, to save him for whatever. I find out that it's in his room with a hand drill. Now the flags are going up. And I said, Patty, he's using a hand drill on him.
During the procedure, Michael receives too much sedation and stops breathing. Help is summoned to assist Michael with breathing until the medication wears off.
And then the nurse, when she was coming out, said to me, that they had to breathe for him, that the doctor put too much medicine. I said to the doctor, as he's moving around, did he arrest? And he says, who told you that?
It wasn't a red flag at the moment. I just was more concerned about getting into the room and seeing him and making sure he was okay. So we did, and then the doctor said there was a lot of fluid, didn't tell us how much.
But in the beginning, he never really told us anything that could possibly happen to Michael that was negative because of what he would do physically to him in surgery or with even putting the tube in his head, he stopped him from breathing.
Unfortunately, the informed consent process these days is really just a piece of paper and having a patient sign a piece of paper, when a real informed consent process should be that dialogue, that conversation with the patient.
The system clings to an outdated model, relying on busy clinicians to keep their patients informed, a holdover from an earlier time when a physician's impromptu advice was sufficient, and when there was little concern about its inherent incompleteness or bias. Current reimbursement models also discourage conversations that would ensure procedures or treatments are truly warranted.
What's informed consent? You know, the original purposes in trying to talk with patients before any types of procedures was actually just to get a consent form. Then it evolved into, well, let's do it informed consent. The idea being that you are giving the patient some information.
Informed consent is a really critical juncture where there's an opportunity to talk to patients and to exchange information about benefits, risks, expectations, all the information that's critical about an upcoming decision that they're going to have to make. And the best way to embark upon it is to really give the patient permission to participate actively in the discussion, that it's not a one-way discussion, but in fact it's a dialogue between two people where there's a key exchange of information and a certain equality of perspective, in the sense that it's not someone on high telling someone on low, this is the way it's going to be, but it's two people sitting down, exchanging really important information about something that is going to happen.
Research demonstrates efforts to inform patients are inadequate for several reasons. Informed consent documents have limited educational value. Many consent forms are written at the level of a specialized scientific journal. 70% of surgical patients do not read their informed consent form, and many patients misunderstand the benefits and risks of their procedure. That same night, the surgeon tells the Skolniks that Michael will need additional surgery to remove the cyst in the next 48 hours to save his life.
Absolutely terrified. The doctor's telling me, my child's going to die. We're talking 48 hours, 72 hours. He's actually just scaring the death out of us.
He said he would...
Microscopically, pinpoint accuracy. Just open the lobes, it was right there, and we'll just extract it. We were so scared to death, we weren't watching what was going on, you know? You're involved in it so heavily, you can't think properly.
Oftentimes in that conversation with a doctor, you just can't listen. I mean, it's a remarkable thing. As a physician, it looks like the person's looking at you. They're shaking their head, they're nodding. It seems as if they're taking it all in. But the truth is, they're scared and they're anxious and they are worried. And in the course of the conversation, it's hard to concentrate. And of course they're nodding. I mean, that's just, you know, social nicety. I mean, they want to send back approval that, yeah, I appreciate you talking to me, doctor. But their ability to listen carefully to what's being transmitted is, you know, markedly limited. They are really in a position of weakness to truly take in the information that's being given them, especially from an authority figure.
Ask the patient to kind of explain back to you what you've just told the patient. I also like the idea of asking the patient for permission to involve other family members, because everybody's got different filters, and for patients who are consenting to a surgery, for instance, they want to think the best of it, but maybe somebody else in the room will temper that wishful thinking with a more realistic view of what could happen if things go wrong.
Patients may not understand or remember critical elements of the informed consent conversation. Having a family member or friend included in these conversations can be beneficial to both patient and caregiver in helping to eliminate possible confusion afterwards. When Patty and David arrive home from the hospital that evening, there is a fax from their primary care physician's office.
There was a fax from our primary care physician that said, do not do anything.
Revisit in 8 months.
Revisit this in 8 months. I want you to just get an EEG. If it is a colloid cyst, it's not doing anything. Basically what the ER said.
On Thursday morning, Patty shows the fax to the neurosurgeon.
And I put it on the front of the chart and rubber band it to make sure that the neurosurgeon saw it. And when I saw him, I said, this is what our doctor said. And he said, he is a primary care physician. And it was basically almost like, you're just a mom, and I'm the neurosurgeon, and he's just a PCP, and I'm the neurosurgeon. You know, my biggest fear was I'm not going to lose our only child. I know that we would not have taken the route we did if, in fact, if we had truly had a true informed consent and had been given the time to think about it, research it, talk to some other medical professionals.
But any good doctor should be able to tolerate the request to say, you know, I'd like to get a second opinion. I'd like to hear what somebody else has to say. And that request can be made in a way that I respect what you're saying, I understand what you're telling me, but I want to hear what somebody else says. This is an important decision for me. Any good physician should accommodate that. Any good decision for somebody who feels that way will entail getting a second opinion. I mean, if someone's uncomfortable, they should do it. They need to do it.
A second opinion can spare a patient a bad outcome, can also spare a caregiver a bad mistake. So I think that it's very important to offer the alternative of a second opinion, and there are not very many situations where there isn't time to arrange for a second opinion. Most of the time, especially in any sizable health system, second opinions can be readily obtained. So I encourage families to not be afraid to ask for that. It should never be seen as offensive to the caregiver when a patient says, I'd like to have another opinion.
After placement of the drainage tube in Michael's brain, he receives 10 doses of morphine, 2 doses of oxycodone, and a dose of the sedative droperidol over a 10-hour period of time. After receiving all of these medications, the surgeon visits Michael and obtains his signature on the informed consent document for the scheduled brain surgery. David and Patty are not present during this conversation.
Physically, he could sign it, but understanding what was going on at the time, he had just gone through a procedure that stopped him from breathing, and at that point, he had more meds that would hurt his judgment, his ability to make a judgment. Here we are operating on a guy's brain. We want him to sign papers? That doesn't make any sense to me. I don't think Michael was capable of doing that, making a good, clean decision. And if I know Michael, he would have said, where's mom and dad?
Particularly when patients are sedated or in pain or in a situation where they're very ill and having trouble deciding, we need to make sure that we're involving the families and that we're involving loved ones or people who know the patient, and that there's a supportive team of people who are involved who understand what the patient's values and goals are, who can help support the decision.
But other issues that creep into all of this is actually the whole set of issues around the level of comprehension that a patient may or may not have. Is it a language barrier? Is there intellect issues? Is there a lack of comprehension of scientific terminology, even put into layperson's terms? And then there's the whole sets of issues around, well, who's actually doing the translating if you are working through translator? Is it a family member? Is it an informed, educated translator? And there's, you know, a whole sets of realms of what is that degree of understanding that's gone on, and how do you validate that degree of understanding in these so-called issues of competency, issues of literacy, issues of urgency and emergency.
A physician's fear of litigation is now coupled with informed consent forms that no longer serve as educational tools, but rather as waivers of liability. The educational conversation between doctor and patient has been lost and replaced by an event in which papers are executed like lease agreements.
Consent forms do not replace that organic, meaningful conversation between caregiver and patient, and yet that's what I fear consent forms have become over the years. The real truth is the use of a consent form is actually a benefit to the caregiver, not really a benefit to the patient.
On Friday, just after 3 p.m., as Michael is being wheeled into surgery, Patty and David inquire about the surgical consent. The neurosurgeon tells them Michael signed the consent form Thursday evening. Patty and David settle themselves in the waiting room for the expected 3-hour surgery. At 9:30 p.m., 6.5 hours later, the neurosurgeon finally enters the waiting area.
And he came out and he bent down on one knee in front of us and he pushed his hat back and said, "This is the worst year of my life." And we said, "How is Michael?" And he said, "I never found the cyst." He said, "I found a little bit of some matter, and I'm thinking maybe I punctured it when I went in with the drain, and so I sent that to pathology. But actually finding the cyst intact, I didn't do, but I did heavy manipulation of the brain." Of which point, I don't think we even heard him. And he said he had trouble waking up, and he'll be in recovery for a little while longer.
When Patty and David get the chance to see Michael later that night in the ICU, they are alarmed at how terrible he looks. They never expected Michael to look like this. They never expected what they saw.
I couldn't even breathe. I mean, he looked like an alien. I mean, to me, his head was like this big. His eyes were swollen shut, everything was swollen, and I was like, we weren't prepared. No one even, I didn't know if that was normal, not normal, certainly didn't look normal to me or to David. And, so that was we were just in shock.
And I said, "Patty, he really hurt him." That's the first moment I realized that he really hurt my son.
Over the weekend, Michael's condition seems to slowly improve, even though his neurological exam indicates he has suffered significant brain trauma during the lengthy surgical procedure. On Sunday, the locums tenens physician, covering for Michael's neurosurgeon over the weekend, removes the ventricular drain because it has not drained any fluid.
The doctor that had been on call was unwrapping Michael's head. Suddenly, we saw Michael had had a craniotomy. And we were both in disbelief. Neither one of us said a thing to the other for, I think, probably almost 12 hours, because I think we were both thinking, how did I miss that? He said, top of the head, open the thing, sounded so simple, excise the cyst. Nobody said, we're gonna cut your head open.
The craniotomy, when we seen that was it for me. We really never were informed. That's definitely one thing I want to say, that we were never informed on what possibly could happen if it went south or we really didn't find it. We weren't informed that he was going to have a craniotomy to start with. I would have blew the trigger on that one immediately. Craniotomy, that sounds pretty serious.
When we look at those patients who have unexpected outcomes and don't run to a lawyer versus that group of patients who immediately seek legal advice, the common thread separating those groups is the element of surprise. If you're well-oriented about the risks, if you are conscious about the choices you're making as a patient, if you understand what life after the procedure is going to be, what your consequences could be if the worst happens, you're much less likely to think that something went wrong after the fact.
2 years prior to Michael's hospitalization, an article published in the Journal of Neurosurgery highlights the benefits, preferred surgical approach, and improved outcomes associated with colloid cyst removal through a rigid endoscopic approach. Because the surgeon did not have experience with this technique, he never discussed this alternative with the Skolniks. They never knew they had alternatives.
We did not have the information we needed to make an informed decision, to be part of shared decision making, to all of us be on Michael's healthcare team
as the medical literature continues to evolve, what we're beginning to recognize is that there are a variety of factors that do come into place in terms of the benefits of outcomes. Volume in some types of procedures, volume that the surgeon has done, volume that organizations have done. Where is it that an individual is in their training or in their experience of their career in terms of how well they're doing with that particular treatment or procedure? So that needs to be, in a lot of our minds, an important part of the informed decision making.
There needs to be complete openness and honesty and transparency about the physician's qualifications to perform a surgery or procedure. A physician should demonstrate that he has competence, and that requires a physician to be honest not only to the patient, but also to himself or herself.
Shared decision-making includes all aspects of informed consent, as well as the identification of a patient's needs, preferences, values, and goals. Discussion on uncertainties of treatment, experience of caregiver, and costs should also occur. Shared decision-making should be a two-way conversation, with the patient and/or family members having a role in the discussion.
We've got to make sure that the choices that are being made are completely aligned with the patient's needs, values, preferences, and goals, and they are making the choice. So it's not a matter of someone coming in and giving them a choice, which wouldn't be what they would choose if they knew all the facts. We got to give them the facts and make sure we're making the choices together that are right for them.
I can't stress enough the value, the therapeutic and life-saving value sometime of having that meaningful conversation, not only with the patient, but with the patient's family and the people who will be supporting that patient when the caregiver's not there. So educating a mother on the things that you're worried about, educating a spouse on the signs of infection, talking to family about realistically what the patient may expect afterwards is not only critical to a patient's satisfaction and level of support they have afterwards, but can actually make the difference between life or death.
I think if there's a possibility for the patient to hear the conversations over through recordings and go home and even have two conversations about decisions that are very important and may have big risks to them, as well as potentially large benefits, and that it's going to involve some weighing, we have to call a time out and we have to pause.
In healthcare today in this country, an unfortunate truth is that there are a lot of medical procedures and tests that are overused. And that means that in some cases, the harm can be greater than the potential benefit. That's why it behooves the patient to make sure, as part of the informed consent process, that they ask the physician, do I really need this? What happens if I don't get it? The truth is that hospitals are out to increase their revenue. They're out to increase their productivity. They want to do surgeries. They want to do tests. But what has to come first and foremost is the interest and well-being of the patient.
Michael suffered almost every possible known complication, and none of these complications were discussed with Patty or David. Since they were not present at the time Michael gave his consent for surgery, they will never know what the conversation entailed between Michael and his surgeon.
I mean, sometimes people think about informed consent as an event, and it really should be understood as a process. I mean, because the decisions about strategies are often ongoing.
The caregiver has to be mindful of the fact that circumstances are continually changing with that patient. So he or she is not dealing with the same patient in the post-op period that they were in the pre-op period. The patient has changed, the circumstances are changed, perhaps the patient's reaction to the medical therapies has altered things, perhaps they've had second thoughts about the course that was originally prescribed. Caregivers who see this idea of informed consent only as a legal hurdle will fail to take the opportunity to continually reset expectations, continually revisit the question of what is in the best interest for that patient as the care continues along a continuum of care.
It's been said that no decision about me without me. Don Berwick has said that many times. And I think the key issue here is that shared decision-making enables the future, what's going to happen to patients, to occur within the context of patient full consent and agreement.
The leadership, both within the medical staff structures as well as within the management of a facility, need to be really tightly working together in terms of setting up the policies, setting up the procedures, setting up the standardization. And it's really leadership's responsibility to make sure that there are steps in place to monitor the compliance with those policies and procedures, to monitor the outcomes of how those variations in compliance are occurring in their organization. And there needs to be the accountability factor in there so that the variations are discussed not only within the leadership structures and the staffing structures, but within that medical staff, so that there can be this ongoing improvement within the organization, so that there is the shared responsibility.
From the C-suite level, I'm afraid that historically, at least a lot of places that I'm aware of in the country, the chief executive officers, the chief medical officers have not been involved in the honest discussion about who's competent, who's not, who's safe, who could be safer, what business practices may impact on the safety of their faculty or staff.
CMS advises hospital surveyors to take the following steps when assessing whether hospitals are compliant with their informed consent processes. Of great importance, surveyors should review medical records of patients who are about to undergo procedures or who are located in a procedural recovery area. They should also interview 2 or 3 post-procedural patients, as appropriate, based on their ability to provide a cogent response, or the patient's representatives to see how satisfied they are with the informed consent discussion prior to their procedure. Michael's complications left him partially paralyzed, partially blind, unable to speak, feed himself, or walk, and psychotic.
Can a conversation change an outcome?
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 Can a conversation save a life?
Michael gave up the fight and quietly succumbed to the continued infections and complications he suffered for almost 3 years, with his parents at his bedside.
He opened his eyes and he mouthed, "I love you," and he died. All for nothing. All because somebody didn't tell us what our alternatives were, what our other options were, what the risks were. He just didn't tell us the truth.
I was so proud to be his father. It was, I miss him bad. I really do miss him. It's been a long time and I still miss, I go in the garage, I found his boots yesterday and fly the jacket. But he was a fantastic person. I mean, I was really surprised that we created something that was so unique. And he just wasn't a kid, you know, he was more than that. He had special qualities to him. He really took care of other people. I mean, he really took care of other people. And he took care of his parents. And
family was very important to him. And he wanted other kids that didn't have family, that he was their family for them as well. And it still stops my breath. Because there are just some days I can't believe he's not going to walk through that door.
Can a conversation change an outcome?
Evidence suggests that shared decision-making can have a direct impact on the quality of health care and outcomes. The well-informed patient has a greater sense of control and is more likely to be a compliant patient.
The outcome would have been so much different to learn that there was another procedure that could have been done that was less invasive, that Michael would still be here.
Can a conversation save a life?
A group of experts who reviewed Michael's case concluded the standard of care related to informed consent was not met. Michael and his parents were never provided surgical and non-surgical options, and the risks associated with the planned procedure, including those associated with the lack of experience and expertise of the neurosurgeon in performing the surgery, were never discussed. The experts also concluded that the small cyst was not the cause of Michael's symptoms.
Can a conversation save a life?
How could we not have asked the questions? How could we so blindly, two intelligent, educated people, so blindly, humbly nod our heads, at least me, of saying yes and just going forward with all of this? And even through the 5 months of the horror and the pain that Michael went through, forget about us and our hearts, the pain that he couldn't speak or tell us. We never asked.
Hello, Michael, Dave, and Patty. Good to see you again. Now that you've shared your needs, your preferences, your values, and your goals with me, and I understand them, we have to decide how to go forward as a group. What we have is a very serious matter here, but there are options available to us, and I'll go over them so that we're all on the same page and that there aren't any unanswered questions. What Michael has is either a cyst or an incidental finding that we've seen on some of his scans.
Can a conversation change an outcome?
Can a conversation save a life? Yes.
Dear Papa, I wish you a very happy birthday, and I hope it's very fun. Please say hi to Nana. Tell Aunt Dixie, Jody, and everybody else that I say hi, and I love you very much.